Welcome back to Every Possible Angle, where we delve into the critical discussions shaping the landscape of transplantation. I'm your host, Michael DeGima, and today's special episode, we're focusing on the future of heart allocation policy. Joining us is the esteemed Dr. Shelley Hall, Chief of Transplant Cardiology at Baylor University Medical Center. Throughout our conversation, Dr. Hall will shed light on crucial considerations underpinning heart allocation, from medical urgency and post-transplant survival to patient access and placement efficiency. Thank you so much for joining us, Dr. Hall.
Absolutely. Thanks for inviting me.
We're so glad to have you. And I think today is a particularly exciting episode because there's so much going on with the allocation change committee that you're part of, and we're going to be speaking about that. But before we get into that, I'd love to hear your background in transplantation. How did you get into transplantation? What inspired you to focus on this field?
Yeah, it certainly wasn't in my master plan. I announced I was going to be a doctor at the age 8 over my Boston cream pie birthday candle,
Really?
and everybody thought I was crazy. There was no medicine in my family. Back then, women were really only encouraged to go into pediatrics or OB-GYN. And so I said, okay, I'll be a pediatrician. And I planned everything in med school, my schedule to kind of shine in pediatrics and show how good I could be. And then I did pediatrics and I'm like, ooh, I don't know about this. And so I'd already had a kid. So I had a perspective as a parent, and dealing with parents when they're sick is not easy. And I was like, oh my gosh, what am I going to do? And then I ended up doing a rotation with the great Clyde Yancey. And that was it. I was hooked. For me, transplant medicine embodies everything I wanted in medicine, is that I got to be super specialized, but also take care of the entire patient. So I was both a general internist for the patient, but also very specialized. And that's kind of how it all happened.
Oh, that's fascinating. That's fascinating. It's an amazing sort of directional change there over the course of your experience. I mean, I'm curious then when your family first heard you were going to be going to medicine, but then heard you were going into transplantation. Was that a big shock to them?
No, I think they kind of, well, it was whatever. They didn't really, it didn't matter. I think the biggest challenge was my husband, who was my boyfriend at the time, was like, wait a second, I'm in cardiology. Why are you going into cardiology? And so then we had to sort of, but he's an interventionalist and I'm a transplant cardiologist. And so we keep our separate spheres, but totally understand each other's space.
And so now for the past few years, you've been part of this committee who has been working on the latest heart allocation change, which has been a monumental effort. And right now, my understanding, we're currently in the period seeking public comment, as well as there's a survey to get feedback of perspectives and values from the community. And we'll be getting into the specifics of how anybody can get involved in that towards the end of the episode. But I guess to start, can you tell us a little bit about what's happening in terms of heart allocation? This is a critical topic for everyone in the space.
Absolutely. I think it's important to understand that our allocation system has been evolving and changing since it first started in the late 80s. As our treatments for patients have gotten more complex, as our methodologies for supporting them to get to a transplant, as our technologies for harvesting organs, all of these things continue to change. And that changes the dynamics of a wait list. So about every decade, we have ultimately changed our allocation to improve problems we have found develop in the current allocation. And so our current allocation, which started October of 2018, addressed a kind of a glut of patients all in the hospital with varying degrees of illness severity, kind of survival of the fittest, waiting for their turn to get an organ, and that wasn't viable. And so our current allocation system separated those groups of patients into 3 different categories: the sickest first, the next sickest second, and the third in the third group. And what it did is it changed our way of practice. Whereas before, these patients, we knew they couldn't survive long enough to get a heart transplant, so they all got durable LVADs if they were a candidate. Only the ones who couldn't get an LVAD for whatever reason were stuck in that system. But now we have prioritized patients on temporary mechanical support as a bridge to transplant. And most centers are going, okay, well, I don't want my patient to have two major heart surgeries, so I'll put in this temporary device and go direct to transplant. But what it means is we've now already, in just 4 years, have gotten, I guess 5 years now, have gotten clogged up again in this high category. And so the new allocation system, which is called continuous distribution, is under development for all the organs. The lungs went live last year with continuous distribution, and all of the other organs were learning a lot from their initial experiences of what things are working and what are not. And the Heart Committee started last year on developing their particular elements of the continuous distribution. And that's where we are now.
So structurally, it's in some ways similar to what's happened in lung in terms of the overall approach of having a continuous distribution rather than concentric circles of distribution, so that it's a score-based approach. But the elements, a lot of the work right now is around the elements within that score specific to heart. And representing the prioritization of what's important, and what are some of the key factors that are currently under consideration?
Yeah, so all organs are tasked with the same categories. And those include medical urgency, post transplant survival, reducing biological disadvantages, patient access, and placement efficiency. So, all organs, those are the five categories of elements or attributes that we have to look at. Now, for the heart, we are looking at many that exist currently, plus adding some new ones. So, under medical urgency, we are looking at all of the statuses. That's our current system, status 1 through 6, as well as the pediatric statuses and how do those blend together.
Hmm.
We're also looking at time that a patient has a durable LVAD in place, because we know the longer they have LVADs, the greater their chance of a complication. While complications elevate them on the wait list, the complications can also eliminate their candidacy for transplant.
Hmm.
Now, the second, reduced biological disadvantage, we are looking at blood type, which already exists, but now we're going to give different points. And then we're trying to address sensitization in some way, the highly sensitized candidates. For patient access, these are mandated by the OPTN that we give priority to pediatric candidates and we give priority to prior living donors. Now, the prior living donors situation is probably not going to be very common.
Hmm.
It's very rare for a patient who gave a kidney, so to say, and now needs a heart transplant. That's going to be incredibly rare, but they will get some points. And then placement efficiency, that's the distance, the geography challenge that we have. The one category we currently do not have attributes for is post-transplant survival. And that is something that we really are wanting to hear from the community on. The community wants us to figure this out. They want us to factor in post-transplant survival. The challenge with the heart community right now for this is that we don't have any reliable formulas or markers of this. To be honest, the categories of patients that have the worst post-transplant outcome are the disadvantaged populations we're trying to help.
Hmm.
Part of the reason they have worse post-transplant outcomes is because it's so delayed and it takes them so long to get a heart that they're really sick when they finally get their heart. And the sicker you are, we know you have increased risk of adverse outcomes. So if we were to just put those categories and lose points because they have a worse post-transplant survival while we're trying to increase their access to mitigate that risk, then we've essentially wiped out all we could do. So this is an area we do feel is very important and we've got to figure it out, but have not developed any kind of models yet to do that. We have 5 years of data of the new allocation system that need to be analyzed.
Hmm.
But all of UNOS resources have been moved to continuous distribution. And so none of that data has been analyzed yet. That was the purpose of collecting all of this data in our current allocation, is to figure some of these questions out. But there's no resources right now to put data analytics people to that task and get us some of those answers. And that's something we need.
it seems like an incredible challenge. In some ways, just in principle, these two factors are diametrically opposed. Being able to have equity in terms of access, whether you're sick, and prioritize the sickest patients, the most highly medically urgent patients, but also try to optimize it. And this comes down to some of the principles of the change that are being considered right now. Is it's both about the need side, who's sickest and needs the transplant most, as well as it's a scarce resource, and so it's utility, saying, well, how do we get the most out of a donor heart that's been provided as a gift in the most years, that's sort of this balancing point that it sounds like the committee is trying to understand how not just people in the transplant field, but all of the public feels about how things should be allocated. Is that fair?
No, it's a very good statement. I think it's important to understand that all of the people that are developing this are transplant people.
Hmm.
They're all volunteering their time, physicians, nursing coordinators, administration, patients, donor families. They're all part of these committees. And we meet on a regular basis to review these. So everybody is working hard on their own personal time. This is not a paid job to try and get this right. And, the more data we have to analyze, it's great. We try not to get swayed by sentiment. The
Hmm.
reality is that things change when you're personally involved. I
Right.
mean, that's human nature. And we have to look at the global good. And, we can't do this in isolation. We need to use more of the hearts that are available. Too many hearts are still going in buckets because it might be increased risk or, ooh, I'm
Mm.
not sure about that. And so a lot of hearts that could very well be used are thrown in the bucket because of concerns about outcome. And the reality is that somebody dying on a wait list, I'll take a organ that gives me an 80% 1 year survival. But right now, programs get in trouble for things like that because if their outcomes drop below 90%, they're flagged. So we have sort of these competing standards going right now where we want to use more organs to get to more people, understanding that not 100% of them will make it. But ultimately, if we can get 80% of our increased use of hearts working,
Mhm.
that is more people alive today than were a year ago from that approach. So we've got a lot of different incentives in different areas of transplant medicine that compete or confront with each other so that we get kind of stuck. And that's, beyond the rules, which are important. You got to figure out the order of the line. The line's always going to be there. The
Mhm.
line's going to get longer, and we're never going to match the demand. Our supply will never match our demand. So these allocation rules will always be needed and they'll always need to evolve. But we do need to continue to work on the other aspects as well.
Just a moment on those other aspects. I'm actually curious. I know in kidney they've looked at certain approaches to try and encourage accepting higher risk donors and higher risk organs. Do you and in order to handle that sort of public reporting and thresholds around outcomes, do you see that ever being a possibility in heart, or is just the landscape so different?
All of the organs have a different landscape, and it's very important not to try and create rules for all organs. And the gravitation of national attention goes to kidneys because they have the most volume. And we have to be careful because rules that may improve the kidney space could worsen the other organs if
Right.
applied all across the board. But absolutely, we are trying to push for ways of all organs to accept more of the donors, even those that they're a little worried about, without repercussions if the outcomes end up. And so that's part of the efficiency task force, and one of the proposals that's out there right now about expedited proposals where they can do sort of a mini trial in a region or a single OPO or a single transplant center and try something different to see if it works. And then if it works, be able to expand that. And so those efforts are underway to try and make things move faster. Because it's like everything, right? The bigger it is, the slower it moves. And so trying to do some of these little pocket nimble things could potentially discover some efficiencies that could benefit the whole organ transplant environment.
You're touching on also sort of the side of innovation and constant evolution. Not only is our understanding of allocation changing, but some of the underpinnings of whether it's technology or new therapeutics or practice changes that are evolving. And I'm curious how you see the continuous allocation impacting flexibility
Right,
as the landscape evolves. The other fact, because the allocation policy is not managing a static thing. It's a
right.
constantly evolving environment.
Right. And that's why the continuous distribution was ultimately settled upon as the new platform to shoot for all organs.
Mhm.
Previously, each organ sort of have a different thing. The liver had the MELD, the kidney, the kidney had their KDPI and the
Lungs had
lung.
LAS, right?
Right. And so, everybody had their own, and therefore you have to have completely different programming. By everybody being on the same platform, first of all, it's efficient. And second of all, you can make modifications quicker to everybody, but ultimately you can make changes quicker for if you identify a problem. And that happened with the lungs recently when they realized that their allocation attribute point system for blood type wasn't producing their intended result, which was to get equal access for O type patients who are limited by only getting O hearts. And they actually found that it was worse. So they were able to analyze that in a few months and go, oh, this isn't working. Let's relook at our attribute points and go, we're just going to move it all to O's. And that helps us on the heart side because we go, okay, a lot of stuff we've looked at is very similar. We'll just do it similar to the lungs. But then we were able to go, oh, look, that's what happened. We're proposing all the points will go to O's for blood type. And so the ability to analyze quicker and make changes quicker is huge because it's one of the criticisms of our system right now is it takes so long to create any change. And part of that is because of the volunteer system. I
Right.
mean, you only meet so often and still pay your bills with your day job. And and then you want to make sure that the whole voice is heard, so all aspects that are touched by a potential change, and that you have reliable analytics to make that decision upon. It's not just oh well, we feel this should happen. That takes a lot of time. And then ultimately you get to that point. We've created a policy. It is passed, and you're going, yay, it's passed and it gets implemented a year and a half later. I mean, that is so deflating. Physicians were used to making instant decisions and has seen instant results. And that was one of the things I had to get used to when I started working with UNOS is wow, this takes a long time. Hopefully the CD platform will reduce that time. It's not going to be instantaneous. You can't make these kind of decisions rashly without good data, good analytics, and good public feedback. That process will always take time. But the rest of it, if we can get analytics to go faster, data acquisition to go faster, and then implementation of our approved policies faster, we should easily be able to cut the total time in half.
And I'm curious as we're talking towards the all of these changes going on and needing to look at data and the flexibility. If you, I mean, the landscape has changed partly because of policy, but also new technologies are coming out as bridging technologies, and in terms of the placement, efficiency, we're seeing longer and longer distance transports going on, and if we can become more efficient through transport, the new policy will accommodate those kinds of technology changes that are or possibilities that are fueled by technology. Isn't that true?
Yeah, absolutely. And one of the criticisms of heart policy is that we are too heavy on the technology aspect in the sense of the support.
Hmm.
Um, and right now our statuses are based upon the mechanical option we use to treat a patient rather than the patient's severity of illness. The thought was, well, that kind of went hand in hand. You used a more complex device if they were sicker and no device if they weren't sick. But unfortunately, behaviors changed with the new allocation, and that's not happening. So we do want an allocation system that gets away from the choice, the treatment we choose to use for the patient, to get more to the disease severity itself as the real reflection of urgency rather than what toy a doctor liked to use. That's on the pre side. Now you've got the donor side, all of our acquisition potentials for getting hearts. We're doing DCD donors now. We have organ procurement systems. We have organ transport systems. We have NRP. So we have all these new ways to transport organs, which absolutely is allowing us to transplant organs over longer distances. But there's a downside to that, and that's what they're seeing with the lung system right now. And that is that you're getting offers from everywhere. The offers are coming fast and furious because the OPOs want to place these organs as quickly as possible. And you're wanting to get organs for your patients. But at the flip side, financially, it has skyrocketed to an untenable level. If it's left unchecked, transplant programs won't be able to do it.
Yeah, no, and making sure that we have sustainable technology, sustainable systems to help more patients get access is critical, and I that's something that we're constantly looking at as well. Is how do we make sure that this is viable for really increasing the overall pool, as at the same time making it outcomes better for every patient.
Sure, absolutely.
And so to get to this point in this process must be have been a tremendous amount of work. You've already told us a little bit about the work stretching back a couple years now to get to this point. It's very high stakes. Can you tell us how people could get involved in this process?
Absolutely. I've been involved now for over 15 years, starting by representing my program as a regional review board member, and I was part of the Heart Committee developing this current allocation system, and now I'm actively involved in developing the new one. The first, I kind of divided into two phases. The first is for transplant people in the space, whether you're a transplant recipient, a donor family, a coordinator. Get involved with UNOS. Look for ways to get involved. There, you can fill out a volunteer form that specifies what you're interested in, your involvement in. Every year, they look through those. They look at the openings and all the various committees that are there, and try and get people involved. That's step one so you're part of the development phase and kind of shaping the future of transplant. The second is what's going on right now, which is public comment. And that is really literally public comment. That is anybody and everyone, not just transplant professionals, not just recipients, anybody who wants to understand and have a voice can log on to the website and look at a particular policy and share their opinion on it, just like any other government document, although there's been lately some government documents that are behind the scenes, but the way it's supposed to be is it's all there for you and you get to review it and share your comment. And all of those are reviewed. When we're on the Heart Committee, we review every one of those comments and where they came from. The second part is help us develop the system, and that is the value prioritization exercise. And everybody can get onto that too. And the reality is you just get on there and it's a brief, maybe 15 minutes, where you are shown two of those attributes and you rank which one's more important than the other, or are they the same? And they do all the different combinations, and they actually switch them up and kind of reverse one and two, and now it's two and one, just to make sure that you are internally consistent with your prioritization. And then that goes into an algorithm and generates sort of what your ranking would be. And we take all of those and in conglomeration together and look at that. And that informs us in when we start to put points to all of these attributes. What does the community really feel is most important? That's where the most points should go and continue on down. And it is vital for this next phase in the heart policy development for as many people as possible to do it. I did the kidney one, I did the liver one, I did the lung one, and I've done the heart one because it's informative. And that's where we are right now. And that's where we're trying to get everybody out to do those two things: public comments on when they read the policy and the value prioritization exercise to help us develop the point system and weights.
So the value survey and the public comment, we will have links in the comments so that you can get involved and take these. It sounds fantastic, and the committee takes this feedback seriously in terms of making these decisions.
Absolutely. We review everything.
And can I just pivot a bit? You've talked a little bit about your involvement and sort of the advice to young physicians in terms of getting involved and taking on some leadership roles outside of just medicine, but into both societies and policy making. You've seemed like you've done that throughout your career. Has leadership, I'm curious, always come naturally to you? Has it something that evolved for you over your career? I'm curious. You do seem to take on a lot of leadership roles in the space.
Yeah, my husband would say I was a gunner in med school, and my kids would say, "Yes, I'm very bossy." But um, uh, I've always been strong in my academic career. But when I finished with my training, I actually kind of gave that aspect up for a while to raise my kids. I have five, and to a busy, busy clinical practice. And it really wasn't until about 15 years ago when we made some changes in our program that I'd really wanted to do. And we were able to expand and do the things that I always knew our program could do, that things changed. And my kids were older by then, and I was able to, and I'm sort of, hurry up to catch up, I think. I wear a lot of hats and do a lot of things, but I'm a really good organizer, and I've learned to be a really good delegator and get people involved. That's kind of my thing, is trying to get more people involved and trying to show them how. A lot of people want to, but have no idea how to.
And I'm curious, is that, at a major teaching institution, is that an aspect that you talk about with young physicians? Is beyond the medical side, the leadership, the getting people involved, the getting people to move the field forward? Is that something that you bring to med students and fellows as you're teaching?
Absolutely. I actually tell them when they are doing a week with me or a day with me or whatever it may be, I say, we're not going to talk about p values. I'm not going to go over the latest paper. We're going to talk about real life. I'm going to teach you the how to's and the wherefores. How do you make the decision? I talk about cost awareness. Do you need those labs every day? Okay, they've been the same. What are you doing differently? I teach them about how the sausage is made, and the how policy directs how we do things. It doesn't matter if I think somebody needs a transplant; they've got to qualify under policy. And then I talk to them about advocacy in medicine. My husband's current president of the Texas Medical Association, very, very powerful medical political institution. And he has a famous saying, in the exam room, we can help one patient at a time, but with advocacy, we can help 100, 1,000, a million patients at a time by getting involved in policy development. And so, although I do it from a different angle that he does, um, I I get these young physicians kind of excited about it and realize how important it is, which most people don't know. And then if they want to, I get them connected to particular organizations to try and start that aspect of their career.
That's fascinating. I'm sure you've inspired many young doctors over your career. So that's so exciting. This has been a fantastic conversation. I really appreciate you taking the time to join us today. Before we go, though, are there any initiatives or events that you'd like to highlight that are coming up that you are involved with or see as important?
Yeah, so some of my other titles, I'm the president of the Texas chapter of the American College of Cardiology. We have our meetings every year and trying to grow and connect the Texas physicians. And then I kind of serendipitously ended up creating a not for profit organization called Women in Heart Transplant and Mechanical Circulatory Support, with an amazing group of women leaders. And it was really sort of an organic grassroots thing where we were connecting through national meetings and gathering and talking about things. And then COVID hit and we had to switch to virtual, and it just kind of grew. And now our motto is to women lifting women, and trying to help these early career trainees and connect with other women in the heart transplant and mechanical circulatory support space, and help them develop research, help them write, help them get on the podium at national meetings, kind of, again, teaching them how the sausage is made when they're not necessarily getting that information from where they're currently practicing.
I do know about that initiative because we're sponsoring an event coming up at ISHLT, right?
Yeah, we're having sort of an open house event. So those of us that are flying all the way over to Prague, it's going to be that Saturday evening, early evening, like 5 or 6. The final details will be coming out soon. I mean, who wants to leave Prague early? So it's after the meeting ends, and we're inviting anybody who's interested, wants to spend a lovely final night in Prague at our reception.
Fantastic, fantastic. Well, looking forward to the event, and thank you so much again for all of your efforts to help move the heart transplant space forward. I can't thank you enough for what you're doing. It makes not only an impact, like you said, to just one patient at a time, but hundreds and thousands of patients at a time. So thank you for your efforts, and for all of you out there to get involved, look for the links or go to OPTN public comment, and there are links to the heart allocation continuous allocation policy change. Thank you again, and we'll talk to you next time.